Good evening, ladies and gentlemen. I'd like to call the meeting to order. We do have quorum in the room. First of all, I want to welcome everybody to the first meeting of 2006 for the Ottawa Public Board of Health. And I especially want to welcome some of our visitors that are here this evening to join us, especially the young people in the crowd. So welcome, everybody. And hopefully your time here this evening will be a worthwhile cause, as well as the fact that you may learn something about our job and my colleague's job in terms of the Board of Health. Having said that, for the room and the colleagues, the order of business tonight will be a little bit slightly different at the start, because there has to be a confirmation of the chair and the vice chair. So based on that, we will come back to our normal procedure. Having said all that, roll call for me, so I'm going to take the roll call if I can get, there we are, thank you. Member Chernyshenko.
Présent.
Member Fleury.
Ici.
Member Kapoor.
Here.
Member Lakin.
Présent.
Member McKinney.
Present.
Member Pinnell. Vice Chair Poirier. Member Kakish.
Present.
Member Taylor.
Here.
Member Tilley. And Chair Kadri, I'm here too. So we do have some regrets. We have a regret, as we talked last meeting, from Member Pinnell, as well as Member Poirier and Member Tilley for this evening's meeting. Declaration of pecuniary interest. Any declarations? Thank you. It's going to be that kind of meeting, no. Confirmation of minutes of meeting of December the 7th. Could we have a confirmation on those minutes? Carried? Thank you. Motion to introduce reports, Member Kakish.
Thank you, Chair. Be it resolved that confirmation of the Chair and Vice Chair report, Chair of Board of Health verbal report, Medical Officer of Health verbal report, Making Healthy Eating and Active Living the Easy Choice report, Towards Better Outcomes for Communities and Patients, Protecting and Leveraging Public Health in Ontario's Proposed Health System Transformation report, Healthy Start Part 3, Toddler Preschool Health report, Ottawa Public Health Activities to Support Syrian Refugees in Ottawa report in attendance at the Association of Local Public Health Agencies 2016 Board of Health Winter Symposium report to be received and considered. Lots of reports.
Are they received? Thank you. That Section 2, pursuant to Section 5-2 of the Procedure Bylaw, the Board Secretary will preside over the first recommendation of the report entitled Confirmation of Chair and Vice Chair. That is in respect of the confirmation of election of the Chair. The elected Chair, we'll come back to the table after, but at the present time I'd like to turn the floor over to Madame Conley.
So on the report recommendation that the Board of Health for City of Ottawa Health Unit confirm the election of Chair Councillor of the Councillor Shad Kadri as Chair for 2016 to be confirmed at the first meeting of each year of its term as required by the Health Protection and Promotion Act. Carried.
Thank you. And item 2 on that is to confirm the election of Member Joanne Poirier as Vice Chair for 2016 to be confirmed at the first meeting of each year of its terms as required by the Health Protection and Promotion Act. Is that carried? Thank you. Now we do have some ceremonial activities, so we'll carry on with that. Good evening. Bonsoir. In October, Ottawa Public Health launched an artwork challenge for all Ottawa students. with the winning artwork to be featured in the Ottawa Public Health's 2015 annual report. A number of entries were submitted which illustrated Ottawa Public Health's work in the community. And what you're seeing behind me is some of that artwork. This evening, I'm pleased to welcome our artists and their families as we recognize them for sharing their artistic talents. At this time, it is my pleasure to invite the following people up here. I would like to invite first the finalists to come forward to accept a certificate of recognition. Ava Peterson Angia. Ava, would you like to come up? The next person, Steffi Peterson Nagia. At this time, it is my pleasure to invite Noah Keats to come forward. Next one is Nina Colleton. Our next recipient is Giorgio Manseri. Giorgio? I'll wear my high heels next time. And our final person coming to the podium is Jenna Wang. Thank you to all the recipients. Now it is my pleasure to recognize, I would also like to take this opportunity to recognize Annie Sabaran and Yasmin Zabian, who unfortunately could not attend the ceremony, certificate of recognition, and we would send those out to each one of them. I would like to announce the winning entries whose art will be featured in Ottawa Public Health's 2015 annual report. This video report will be shared with major funders, partners, and throughout the community. In recognition of your winning artwork submission to the 2015 Annual Report Artwork Challenge in the Family Health category, it is my pleasure to invite Eva and Safi Peterson Angia to come forward. Congratulations.
And here we have little bags for you as
in recognition of your winning artwork submission to the 2015 Annual Report Artwork Challenge in the infectious disease category, I invite Jenna Wang to come forward. Jenna, congratulations. And in recognition of your winning artwork submission for the 2015 Annual Report Artwork Challenge in the following 3 categories: chronic disease and injury prevention, environmental health and emergency preparedness, I invite Giorgio Manseri to come forward. Giorgio. Congratulations to each of the winners and all the people that participated in this event. And I want to invite you again to come back next year and participate even in the following projects coming forward, okay? Thanks very much. Have a great evening. Thank you, and we're back to the committee agenda. Communications, there were 13 communication items that have been received and are held on the board file. Can we receive those items? Received. Thank you. The chair of the board health verbal report we will hold. Item number 3, medical officer of health verbal report we will also hold. Item 4, making healthy eating and active living the easy choice. We have a presentation on that item, so we will hold that. Item number 5, towards better outcomes for communities and patients, protecting and leveraging public health in Ontario's proposed health system transformation. And again, we have a presentation on that item, so we will hold that item. Item number 6, Healthy Start Part 3, Toddler and Preschool Health. And again, we have a presentation on that item, so we will hold that item also. Item number 7, Ottawa Public Health's activities to support Syrian refugees in Ottawa. Do we have any comments on that from the committee or any questions? Otherwise, Member Fleury?
So it's a very short question. When I look at the national statistics, we seem to, unless I'm wrong, but we seem to be welcoming as many refugees from year to year. I question if our data locally is just the blips in the amount of people that are coming in the series of the first 3 months, or if there's actually a trend that indicates that we're bringing in more refugees than in other years, and if so, what's the difference? I'm unclear about that. Sorry.
Through you, Mr. Chair, I think the answer is we don't know yet. It's a little early to say. Certainly, it would appear that the federal targets of the 25,000, particularly from Syria, are an increase over and above the routine, the annual numbers. But in terms of those coming into Ottawa specifically, certainly we do get refugees in Ottawa every year, and it's not clear what the one-year pattern will look like. The December and January pattern looked like a sudden influx of larger numbers during a few-week period than we're used to, and we're anticipating that from a public health perspective for another couple of months, probably. But what it'll look like by the end of the year is hard to know.
Member Kakish?
Thank you, Chair. I'll just take a crack at it. I think Dr. Levy had it right there. It's the influx and the time period, or within the time frame that it's happening. So now we have, I think, a little over 700, but the Catholic Center for Immigrants and Carl Nicholson, who's the federal point of contact for those government-sponsored refugees, is dealing with a higher number, and he will be for the next month. Now that 1,200 number for the end of February has been pushed back a bit, but within the next month or so we'll be up to 1,200, and then by the end of the year around 2,000. So for those agencies and for us, it's the time frame more than anything else as well. So it's being done in a short time period, and therefore the resources from that perspective, I think, more than anything else. We can look back at the numbers and send that to colleagues in terms of the overall numbers, but the time frame, I think, is the most crucial component to that.
Thank you very much, Member Kakish, for that update. And by the way, congratulations on being appointed the council liaison on that particular task force. So thank you. Can we carry item number 7? Receive. Item number 8, attendance at the Association of Local Public Health Agencies Alpha 2016 Board of Health Winter Symposium. And the recommendation here is that the Board of Health for the City of Ottawa Health Unit approve the attendance of Vice Chair Poirier and Member Kapoor at the Association of Local Public Health Agencies Board of Health Winter Symposium to be held from February 24th to 25th in Toronto. Can we approve that recommendation? Or are there any questions? Member Fleury?
Mr. Chair, you'll find my question odd, but depending on the results of the discussion relating to patient first, I'd like to hold the item because I'm unsure about elements of patient first, and I don't know if our voice will be presented through our representative at that board.
Okay, so we'll come back to that then as an item. No,
Yeah.
that's okay. Thank you. So now moving back to the start of the agenda, or at the front part of the agenda, which is the first item on there is my verbal report. Well, good evening, everyone. Thank you for joining us at our first Board of Health meeting in 2016. To start the meeting, I will briefly reflect on 2015 and look forward to 2016. Beyond a doubt, 2015 has been a remarkable year for the Board and Ottawa Public Health. Numerous accomplishments and milestones come to mind. In 2015, the Board developed new strategic priorities to guide Ottawa's public health for the next 3 years. These priorities aim to build a healthier Ottawa. We adopted an immunization strategy that aims to increase the number of children vaccinated. We also endorsed Ottawa Public Health's 5-point plan to provide Ottawa families with the right care at the right time. And the Board also approved an innovative trial project called Ottawa Safe. The project is a new way to share restaurant inspection results online. I'm now looking forward to working with staff and our board in 2016 on many new initiatives and projects. So far, January has been a busy month for our board members and our staff. Ottawa Public Health continues its effort to ensure that school-age children's immunization records are up to date. Since last spring, tens of thousands of phone calls and letters have been sent to parents and guardians, and Ottawa Public Health continues to receive hundreds of communications daily. Since Ottawa Public Health started the notices of suspension on December 15, 2015, over 3,800 Ottawa students have been suspended at least one day from school. because their immunization records were not up to date. This step of suspending students, while not the ideal, has proven to be very effective. For the schools that have gone through the full surveillance, the databases are 96% updated. The last batch of suspension in elementary schools will be sent out tomorrow, with suspensions in high school to be completed by the end of March. I understand that Ottawa Public Health staff are working closely with schools and parents and guardians so students may return to school as soon as possible. I would like to thank staff who are working long hours to respond to questions from parents and update students' vaccination records as part of this Every Child, Every Year immunization initiative. I would like to remind all Ottawa parents and guardians that they can report their child's immunization records to OPH by phone, online, fax, mail, or by the immunize.ca app. Last month, Vice Chair Poirier and Councillor Mathieu Fleury attended the OPH annual all-staff meeting with the theme of All for Public Health. Public Health for All. And the meeting provided an opportunity for staff to hear from community leaders about community partnerships and collaboration. Thank you to both for attending that meeting on our behalf. The following day, on January 27th, Ottawa Public Health participated in Bell's Let's Talk Day. This day seeks to break the silence around mental illness and support mental health all across Canada. As part of this day, OPH staff promoted on CTV News at Noon, OPH's Have That Talk videos. These OPH videos aim to give parents the knowledge and resources needed to talk about mental health with their child or teen. Looking forward in 2016, the Board of Health and OPH will continue to advance healthy eating and active living, positive mental health, sexual health services for priority population, and reduce falls for older, along with many other major projects. Finally, as the board is aware, Sherry Negro, branch manager for health promotion and disease protection, announced earlier this month that she will be retiring in April after more than 25 years of service to Ottawa's residents and Ottawa Public Health. And I think, Sherry, the motion that Councillor Fleury made, why? Sherry has been an exceptional contributor to public health in Ottawa, advancing the health of our community. Her outstanding ability to work with city partners and other stakeholders has resulted in sound public health policy, programs, and services that have benefited residents of all ages. Next month, partners, board members, and staff will be celebrating Sherry's accomplishment at her retirement party. A little young to anyway. Please join me in collectively wishing her the best as she starts this new chapter in her life and recognizing her many accomplishments over the past 25 years. I think that deserves another round of applause. And with that sad news, those are my notes on this verbal report. So can we accept or receive that report? Thank you. Thank you very much. I'll pass the floor over to our Medical Officer of Health, Dr. Levy.
Merci beaucoup, Mr. Chair. Bonsoir. Good evening, everyone. I want to start by acknowledging that anyone who noticed Councillor McKenney cleaning up the coffee, it was my coffee. So apologies to Councillor McKenney. Yes, indeed. Yeah. So being the first meeting of the year, I haven't had an opportunity to wish all of you a Happy New Year individually, but I do wish you a collective Happy New Year. And I also want to especially acknowledge tonight as the new year for our Chinese, Korean, and Vietnamese friends and others who celebrate the Lunar New Year, and for our staff, and to wish them a Happy New Year as well, a New Year of happiness, and acknowledge their presence with us tonight on this special day for them. I also do want to echo your comments, Chair Kadri, and your remarks about Sherry. Of course, you'll have the opportunity later this evening to hear from Sherry again, as you have so often in the past. And I know that you've appreciated her diligent and thorough work on your behalf and on behalf of the community. I want to publicly recognize her tonight on behalf of our staff and her colleagues. Sherry will be greatly missed by many, myself included, of course, none more than me. Her leadership and her wisdom has been invaluable to me personally and to all of us. We've been busy on a variety of fronts since our last meeting. Some of it you read about in the press, but not all of it. We've commented already this evening about the influx of the several hundred refugees that we saw in January here into Ottawa. And our work at Ottawa Public Health with municipal and community colleagues is outlined in the report in your package, and I do want to acknowledge Erin Burry, who has been a tremendous colleague at the municipal level on this file. As of today, from a public health perspective only, we've run 10 outreach clinics now in the immunization clinics, and we've provided vaccines to a little over 500 refugees. We've also provided just a little under 400 dental screenings, and we continue to assist with the infection prevention and control measures at temporary lodging sites, which are now operating in hotels in our community. Like many of the partner agencies, the city and others in the community, at OPH we're literally adapting our plans virtually every day to address emerging needs and changing situations. So it really is a testament not only to the adaptability and dynamism and flexibility of our own staff, but indeed those obviously within community and social services at the city and other organizations affiliated with Refugee 613. Another new and previously unforeseen pressure, which was not on our radar at all when we last met, is the widely publicized Zika virus situation in the Caribbean, Central and South America. And Zika virus infection, of course, I think now pretty much everyone knows, is caused by the bite of an infected mosquito. And it seems to cause a relatively mild and time-limited infection in most adults who contract it. But although still unproven, there are growing concerns about the virus's potentially devastating effects on unborn children. And so public health agencies around the world have been recommending that pregnant women and those considering becoming pregnant discuss their travel plans with their primary care provider and consider deferring travel. And needless to say, we've had many inquiries, and we've been working with our healthcare provider partners on providing information not only to them but through them to the public. I will add, of course, people will be aware that in Canada we do not have the mosquito that spreads Zika virus. So like Chile, apparently, I never knew that, but like Chile, we're one of the countries in the Western Hemisphere where there is no local transmission of Zika. There have been other significant developments in the last few months too. Firstly, I'm really pleased to say that there appears to be a growing interest at both the provincial level and the federal level in alcohol as a public health issue. We've discussed that issue around this table before, and my views on it are well known, that I think it's one of the under-recognized major contributors to ill health and general societal disruption in our community. And in December, the provincial government announced consultations on the development of a provincial alcohol policy framework, given the necessity to explore ways to mitigate potential health impacts of increased access to and use of alcohol. Also, just last week, Canada's National Chief Public Health Officer, Dr. Greg Taylor, whom may be known to some of you, Dr. Taylor made alcohol the subject of his annual report to Parliament on the state of public health in Canada. And he warns of the potential health risks from even low levels of drinking. We know that locally in Ottawa, alcohol continues to cause a great burden of illness and death, and this month, coincidentally, we've started a community conversation about alcohol on our social media channels. We really want to raise awareness and learn from the community what their perspectives are in terms of alcohol and the culture of alcohol consumption. So until February the 29th, the public can share their views online at haveyoursay.ottawa.ca or donnez votre avis ottawa.ca. I think that's correct. Anyway, .ca, to access a short bilingual survey. Of course, at Public Health, we'll take comments through all of our other usual channels, phone, email, and any other social media vehicle that there is. And we'll build the results of those conversations and an analysis of Dr. Taylor's report into our own work towards reducing the harms associated with excessive alcohol use. Aside from alcohol, December was a typically busy month for the province too. We got our usual avalanche of new and changes to the standards that the province continually update in what they call the evergreen process. But we also heard that the Ministry of Health and Long-Term Care had released the discussion paper regarding reform to the healthcare system in Ontario. And although we'd anticipated that release and the potential that local public health agencies might be included in the ministry plans, the timeline for consultations on that paper is very short. We only have until the end of the month as a community to respond to that discussion paper. So that is why the item is on tonight's agenda, and that is why we need to move towards a recommendation in one meeting. Just before ending, the other thing just to draw your attention to, you know, of course, that at OPH we continually strive for quality improvement. During the next several months, we'll be gearing up for our accreditation survey visit, which will take place in June this year. And we'll also be assessing the results of our 2015 Quality Improvement Plan and collating the performance measurements for the provincial accountability targets. So as in previous years, you'll be receiving a report at the next meeting about our performance. And at this point, we're tracking towards meeting at least 80% of our targets, and we continue to stay flexible and adaptable in our work so that we can meet the emerging needs and continue to perform well against targets. When you receive that report at the next meeting, you'll also be receiving the annual report, and you'll have an opportunity to review all of that at that time. So that's all I was going to say tonight, but of course happy to answer any questions as always. Merci beaucoup.
Thank you very much, Doctor. Any questions or comments on Dr. Levy's report? No? Okay, thank you. Can we receive this report? Thank you. Moving on to item number 4, making healthy eating and active living the easy choice. I'll invite Ms. Sherry Negro, Manager of Health Promotion and Disease Prevention, along with Ms. Helda Chow, Program Manager for Chronic Disease Prevention, to come and make the PowerPoint presentation for us.
Thank you, Mr. Chair. While Hilda's getting set up here, I just want to give a note of appreciation for the thank you and the recognition tonight. It certainly is mixed emotions, as I'm feeling actually a little sad about this being the last board meeting, but mostly I'm profoundly grateful for having had the opportunity to work at Ottawa Public Health. I think most public health practitioners behind me will resonate with the fact that public health is really a calling, and And it's a sense of profound gratitude that I've had to be able to work with these fine practitioners and in a field where I really think we make a difference by not being in front and center all the time. So thank you very much for your recognition this evening. Speaking of health promotion and prevention, we're talking about making healthy eating and active living the easy choice this evening. Hilda Chow is the program manager responsible for the Chronic Disease Prevention Unit, and we're here to table this report and to seek your approval for our plan to make healthy eating and active living the easy choice in Ottawa. The issue, of course, that concerns us is overweight and obesity, as well as the obesogenic environments and unhealthy behaviors that contribute to this complex and wicked public health problem. I cannot say that over the past 4 years we have seen improvements in the population health statistics. While I am cautiously optimistic that the trajectories have flattened, when one is monitoring for change in social norms and system-wide issues, it is expected there will be a lag time before we see significant health impacts. That said, we continue to feel the urgency of the health burden and the health care burden. Physical inactivity and unhealthy eating costs us almost $6 billion a year in direct and indirect costs in Ontario. So healthy eating and active living has been a priority for Ottawa Public Health over the last term of the Board of Health. We are looking to build on that work to date and to leverage the partnerships and momentum that have evolved. While health education on what it means to eat well and be active is important, it is becoming more evident that to truly reduce chronic diseases such as cardiovascular disease and cancers, efforts will need to focus on the environments, physical and social, where people live, work, learn, and play, so that people can access fresh fruit and vegetables when they stop at any food retailer, that they spend time outdoors because it's fun and relaxing, they walk to work because it's convenient, and they drink water because it's available. And that will depend less on the individuals themselves, but on the systems that set public and organizational policies and renormalize back to basics lifestyles. In analyzing the progress to date, in listening to our residents and our partners, and in looking at the evidence base, Ottawa Public Health has identified 5 strategic initiatives that will deliver on the strategic direction set by this board, which is to inspire and support healthy eating and active living. We will use lessons learned from the policy work that we've done in the childcare sector to expand the reach of healthy eating and active living guidelines. This will be done by developing tailored guidelines that build on the key messages that Ottawa Public Health uses to promote eating well, being active, and feeling good. You have a little Z card on your, at your desk there this evening that shows some of our key messages. And we'll be able to translate these or tailor these to new settings, populations, and activities. So we have a number of current partnerships that are helping to expand these key messages to after-school programs, homework clubs, workplaces that will be able to advance active transportation, and employers to reduce sitting time for office workers. Our second strategic initiative is to work directly with food retailers to make it easier for the consumer. With the implementation of the Making Healthier Choices Act expected in January 2017, OPH will be working closely with food service chains that have more than 20 outlets to assist them in being ready for the new legislation. The Act requires that caloric information is available on the menu, enabling consumers to make more informed choices. OPH has advocated for this legislation, so we are pleased to see the province moving forward. As well, OPH is providing supports to corner stores that are looking to improve the quality of food options. As we know, convenience and corner stores are stocked with heavily processed items that tend to be high in sugar, salt, and fat. As well, we know that there tends to be a higher density of convenience stores in neighborhoods that have a lower socioeconomic status. And likely these residents have less access to transportation and therefore are more dependent on corner stores as their primary source for groceries. So as noted in the report, approximately 1/3 of Ottawa neighborhoods have the lowest socioeconomic status, yet contain over half of the convenience stores in Ottawa. A number of corner stores have expressed an interest in providing healthier options to their clients, and we are looking to the examples from other jurisdictions such as Toronto, Boston, and New York City to support local corner store owners to sell items such as more vegetables and fruits. The third strategic initiative is working in the food security sector, where the issues of sustainability and system capacity are a continued challenge. Along with local partners in the food security and social services sector, OPH will be working to find solutions to these challenges. For example, healthy food procurement has been a common issue across nonprofit initiatives such as the school breakfast program. We are working with Just Food and the Food Producers Network to find mechanisms to centralize food purchasing and leverage wholesale buying power. This systems-level solution would strengthen the collective purchasing and distribution power of nonprofit organizations in Ottawa while increasing efficiencies across all programs. As well, OPH is working with other community organizations such as the Ottawa Food Bank to establish nutritional guidelines for purchasing. This aims to increase the availability of healthy, affordable, and culturally appropriate foods at member agencies. The fourth strategic initiative, we will continue to encourage walking and cycling as part of our daily routine. Active transportation promotion that results in a 10% increase in physical activity could reduce direct healthcare expenditures in Canada by $150 million a year. This does not include indirect costs such as lost productivity due to illness, premature death, or a range of other factors, including mental health and poor quality of life. Through measures to increase safe walking and cycling, governments can reduce air pollution, greenhouse gas emissions through reduced vehicular traffic, and achieve better health resulting from more physical activity. By working with partners, OPH will work to make human-powered transportation safe, convenient, and comfortable option for moving with and through our communities. And finally, OPH plans to advance natural and built environments. We see this as one of the most promising areas for development, with growing awareness of the profound health impacts of place. The importance of the built environment has been well documented, and our partnerships with our municipal partners in planning and growth management and public works have resulted in the health lens being considered in various technical committees and in various planning documents, such as the Transportation Demand Management Plan and the Pedestrian and Cycling Plans. With strong evidence emerging that shows that spending time in nature has independent positive effects on health and well-being, this is a natural synergy, pun intended, with other municipal departments to collaborate on activities such as the Urban Forest Management Plan, the Healthy Kids Community Challenge, and the Going for Gold designation with Walk Friendly Ontario. There are a growing number of researchers, health advocates, and non-health partners who are vested in promoting time in nature, and it is seen as having great potential for improving health equity across all populations. Nutrition education alone is not enough to address the issue of food environments. Changes in legislation are essential, and we are pleased to see the increasing activity internationally, provincially, and most recently with the fall election federally. The new Liberal federal government's mandate letter includes a commitment to promote public health. It supports, and Ottawa Public Health supports the federal government's commitments to make changes as they address 3 issues of concern to our frontline public health staff, and they align well with the board's strategic direction to inspire and support healthy eating. The introduction of new restrictions on commercial marketing of unhealthy food and beverages to children, similar to those already in place in Quebec, are welcomed. Studies show that foods children eat and ask their parents to buy can be influenced by advertising, and over 40 organizations, including the Healthy Kids Panel and the Ontario Public Health Association, have published and endorsed statements to support the government legislation to ban advertising to children under 12 and 13. We are also supportive of the regulations to reduce trans fat and salts in the food supply and to improve point-of-purchase information with food labeling that will add information about added sugars. This work will complement the provincial menu labeling regulations as they move in and further empower consumers to make informed choices. So health promotion is both an art and a science. And here's some art from a photo voice contest. It works best when there's a multi-strategy approach. So while health education and skill building are important components, We need to more and more focus on improving the social and physical environments that influence our choices. We believe that the healthy eating and active living strategy, with the 5 major initiatives, which will be to expand the HEAL guidelines, work at points of purchase, build food systems, increase active transportation, and advance natural and built environments, will contribute to making Ottawa a city where the easy choice is the healthy choice. I'd welcome comments or questions at this time.
Thank you very much, Ms. Negro. Any questions or comments? Councillor Fleury?
Yes, thank you for the great presentation. I struggled with it, I have to be honest, because it said so much. There's just so much content, and the approach is wide. I recognize, though, it is a strategic initiative, and I recognize that. I guess I would have a series of questions that relate to what are we sending to the minister? Because in my mind, we should actually prioritize, and if you're asking me personally, I think it should be menu labeling or food labels and sugar. And I think that, you know, sometimes in the letters we send, we might get lost because there's so much content that I don't know if the board would be comfortable to focus in on one issue. There's just so many things that we could look at if we'd said, as a board, we'd like, as part of the strategic initiative, as part of the letter writing, to support one initiative. And I'd like to hear you on, I'm proposing sugar or food labeling, but I'd like to hear from you on that.
I'd certainly be happy to hear other opinions. I mean, the federal government has already made commitment to those 3, so I'm hoping that they're planning to advance on that, and we're more than happy to support all 3 of them. But they're the ones that they've identified as for action in this term of their government. But if we want to single out one as having more profile and sugar being the flavor of the day, sorry. I'd be more than happy to take direction.
Well, I don't want to reinvent the wheel. I just find that in my mind, I would much rather us propose an approach than to say we're supporting you in this initiative. I find that too often letters are saying either we support or oppose, but too little is put on solutions and actual measures that can be implemented. So it'd be nice for us to bring an idea, whatever one of the 3. I mean, it could be sugar in my mind, and propose what's the approach that we would, as a Board of Health, favor in Ottawa, because or else it leaves so much open. I find as governments we get caught up between levels and who's responsible, and then, you know, looking at the further point of the Bill 55 and the calories posted. I thought it was a great initiative. When you read the fine prints, it only applies to restaurants that are 20 locations or more. I don't think that meets the goals of what Ontarians and Ottawans want. This is about knowledge. It's about information. It's about, you know, making the right choices. So for me, you know, often I find it's we have the goal and then we lose track through it. And I just want to make sure that as part of this submission, we actually narrow in what would we like to do as a Board of Health, and we're looking to our experts to give us that and say, hey, in Ottawa, here's the focus we should do. We might not resolve everything else, but at least we can point to a bit like Smoke-Free Ontario Act, right? We were the leaders here in Ottawa, starting, and I think we could do something interesting for food labeling or for sugar.
Through you, Mr. Chair, thank you very much. What we've tried to do in the strategy that we brought forward is to acknowledge exactly what you're pointing out, what a very, very broad waterfront it is to address something like this, an issue like this, where so many in the community, individuals, different levels of government, all have an important role to play. And Sherry's point that these health promotion works best when one's approaching it from multiple different angles, almost is the other side of the coin of what you're saying. So I would say if there was one thing that we would want to focus on as an organization, it would be something that creates a healthier environment than we live in, rather than something that creates a burden potentially or more onus on individuals for individual choice and individual behavior in the absence of a healthy environment. So what I mean by that specifically in this context is we think that the labeling on balance is a good thing. It enables people to be more informed and to make more informed decisions about what they consume. But it doesn't address the softer side of the choices that people make. Everyone knows that that one of the things at the at outlets are power walls. It used to be power walls for tobacco at the point of the cash registry. Now, even in pharmacies, even in grocery stores, it's chocolates and candies. So it is that kind of environment which sets the tone for the kinds of decisions people are making. If I was going to choose one based on my understanding of the science that leads to behavior change and healthier choices, I'd probably choose of the smorgasbord that's in front of us, another bad pun. I'd probably choose advertising to children as possibly the one that would make the biggest impact over time. But I guess I'm reluctant actually to go down the road of making specific choices because I think it is such a broad sort of environment in which one can have a lot of impact. I do think, though, that you raise a different interesting point, which the Board of Health can ask governments at different levels to do things, can work with partners. Certainly on your point that the menu labeling only is something that only certain restaurants, larger restaurants and restaurant chains, our department works with smaller groups to try and carry that through even where it isn't required. But the municipality itself could take a leadership role as it did in the tobacco situation. And there could be opportunities, especially, for example, around 2017, where the municipality demonstrates that it is prepared to set policies that puts it in front of the curve in terms of creating a healthful, nutritional environment. So I think there are opportunities, and you've raised some interesting challenges for the board, for us at the staff level, and for the municipality.
Thank you. Is that it, Councillor? Member Lakin. Oh, sorry.
I usually do go on a little longer, so I'm sorry about that.
I was not expecting such an early termination.
I think a healthy eating pause is appropriate.
Oranges.
It's a healthy choice.
Thank you. And thanks, Sherry, to you and your team for this report and trying to implement an important initiative that the board established. I wanted to ask you, with respect to the healthy eating part, and in particular, trying to achieve some behavior change. You mentioned earlier in your presentation you've had conversations or have thought about targeting some of the higher risk parts of our city with respect to food choices and having conversations with convenience stores in certain areas. Was there any consideration given or discussion about the use of financial incentives as a means of improving food choices available in those particular establishments, for example, using tax credits or other such means, given that in order to encourage a change of eating choice, there has to be a healthy choice available in the food supply. And I just wonder if in those conversations anything related to incenting suppliers to provide healthier choices was part of the conversation.
Through you, Mr. Chair, I think that's a really, really important point because incentives really do make a difference. There are a number of kind of institutional barriers to adopting some of these things. There's cost to adopting some of these things. Even when we talk about just offering more fruits and vegetables, now you need more refrigeration and things like that. So as part of what we're doing as we learn is to document some of the lessons learned, and then we would be able to move forward with them. We have tried to do, provide some financial support. So one of the barriers to menu labeling is the cost of doing the nutritional analysis. And one of the incentives that we've done is try to absorb some of that with some of the work that our dietitians have done in the past to be able to relieve that burden. That's fine on a micro project, but when we get into getting these to be adopted by more and more agencies, we'll have to figure out other systems to be able to do that. The tax incentives, I think, is really interesting. It takes us right into the complexity of regulations around provincial and municipal taxes. Zoning bylaws, for example, licensing, all those things can serve as different levers or different barriers to be able to move forward on that. So I don't have a really good example of what we would turn it into right now, but I think it's a very important consideration in all our plans going forward, particularly with food retailers.
Thank you. Thank you, Sherry. I know other jurisdictions. I'm thinking of a couple of American cities where high needs neighborhoods that rely heavily on corner stores for their food supply have created incentives for suppliers and owners to do simple things such as food placement and food choices. So I'd be interested in what you discover as you explore this further. Thank you.
Thank you very much, Member Lakin. Member Kapoor.
Thank you, Chair. First, Sherry, let me add my voice to those lauding your achievements, and you've got a lot of great accomplishments that you can look at as a legacy, so congratulations. And I did not applaud your retirement. I applauded the second time around when we were congratulating you on your career. To the other point regarding our letter to Minister Philpott about her mandate letter, I think just putting a different lens on it, there's some things that can only be done by the feds, and I would encourage them over the 4 years to do everything in her mandate letter rather than just pick and choose, and that will make our lives easier and we can fill holes as from our point of view. The question I had originally was about the section of the report on promoting walking and cycling for active transportation and leisure. Two parts to the question. One is the list of initiatives that we're doing with the elementary schools and Safer Roads Ottawa. It sounds to me very familiar when I think we have been doing work on that. So I'm wondering if you can let us know how this is different or furthering what is already in our work plan and what's been reported to us previously. And then the second question, it's related to the built environment and the initiatives and partnering with those who are doing those developments. I know we have worked with NCC before, and I'm wondering if that built environment and complete streets concept or lens has been is part of the, if we've been working with NCC as they initiate their consultations and their deliberations about what's going to be coming in at LeBreton Flats.
Thank you, Member Kapoor. Through you, Mr. Chair, around the walking and cycling, this is definitely an area that it's building. It's a continuation on. So we continue to work with schools. We continue to work with, we're trying to do more outreach to parents, raise the visibility, leverage the work that's happening with the city. It's considered that there's going to be more and more opportunity to drive active transportation, and the city's opportunity is really around the rapid transit and the Ottawa on the Move program. So the momentum is started, and we're just trying to make sure that Ottawa Public Health is supporting what the city is doing to be able to increase access to public transit and support the active transportation. So some of these are city programs that we're promoting, so there's a cross-promotion, advancing things around Safer Ottawa, Safer Roads Ottawa. There are a number of campaigns that have gone on. Ottawa Public Health continues to support those campaigns. We've been a very strong voice in terms of advocating for the vulnerable road users, and I'm really pleased to see that some of that is showing up in terms of the collision statistics. There is some reduction in cycling and pedestrian collisions, but also in the offerings that the city's doing. We put a lot of attention to visibility and being safe, be seen, and the new initiative that's coming, the See Eye to Eye, is really best practice in terms of if we can train our kids to make sure that there's eye contact with the driver before they cross the road, that's really going to reduce injury. So I appreciate your comment that this doesn't feel fresh. It's not brand new. It is building, but this is particularly with the opportunity with Ottawa on the Move and the the transit that's being established. I think Ottawa has an opportunity to really make this a premier offering. Working with the NCC, the advancing natural environments. What's really interesting about working with the built-in natural environment area is that people are really, really committed. People are really vested in, the Complete Streets people are very vested because they know it works. And the people who are there around promoting the natural assets of Ottawa are really vested in making sure that we have good quality green spaces, that we're thinking about our trees, that we're working with our partners like the NCC. So I very much appreciate your comment around working with other partners like the NCC. We will certainly be including that in our plans. And, we know that we all have shared objectives, and they're not just paper objectives. People live, breathe, love this stuff. So I think there's a real opportunity.
Member Chernyshenko.
Yes, I suppose I just wanted to offer a comment and thanks for continuing your work in this area. I know it is a vast area, and I take Councillor Fleury's point about the challenge, of course, is that there's so many aspects to it and so many levers, if you will, that it is actually very hard to narrow it down to. Someone might choose that it's sugar and it's, in order to try to focus, and yet someone else might say it's about complete streets, and the fact is it's all of those, which is what makes it so hard. It's what makes it such a difficult, area to see progress, because it's many little pieces that you advance towards a bigger whole. I've just found that in a number of on a number of issues at various committees, having the public health voice brought to it has tremendous value. When you think of streets and complete streets as a transportation issue and a transportation problem, maybe it's an economic one by getting, the survival of streets and more street life happening, but to have the whole public health aspect brought to street design, there's a growing recognition or understanding of that, but I think it's relatively recent that people have come to understand the whole the public health promotion side of the way we design our streets and our communities and our squares and our LeBreton flats, our Lansdowne parks, that's so important. So I guess I would say that I'm not one to try and choose one or two key ones to focus on. There are so many, but maybe at a given time there will be an opportunity. It will be timely when we see a provincial or federal government initiative that we can say now's the right time to support that one, or put our voice behind that one, or a city project. I felt it helpful in the Main Street, the debate over whether we would make Main Street a complete street, to have the public voice, the health voice come in. That was a bit of a surprise. People were expecting it to be a battle between suburbs and downtown over will the traffic flow, and to have the public health voice was and research was very helpful. Thank you.
Thank you very much, Member Chernyshenko. Member McKinney.
Thank you, Chair. I echo most of what we heard tonight, and just the whole importance of as we're moving forward to recognize how our built environment, how our architecture changes behavior, how and what that can mean for public health, and I understand where Councillor Fleury was coming from in terms of let's focus and make sure that that what we're highlighting gets the attention that it deserves. What I'd like to ask is I go back to active living and especially around promoting the walking and cycling, and we've got a new federal government with very strong mandate letters. The health minister, as we're focusing on here, but we also know that there's going to be funding involved for moving projects forward, infrastructure projects, and we've got a transportation master plan at the City of Ottawa where we've got some $70 million earmarked for cycling infrastructure. We have a little bit for pedestrian too, but I don't remember the number. It was minuscule. But it would be for us to kind of pay attention as a Board of Health as well to when that opportunity comes up to get projects on the list, if we can accelerate some of that. We do have a light rail system coming on board in 2018. It would be really nice to we talk about complete streets and we talk about a vision zero for our streets and our sidewalks, pedestrians, all of our users of the road, where we really can find a way of getting to zero fatalities and serious injuries on our road. Having the Public Health Board include that as a recommendation to the federal government when we have the opportunity to ask for federal infrastructure funding, I think would be something that I would like to see, certainly.
Through Mr. Chair, could just make sure that I understood the point, because I started to go, so there's an opportunity to advocate, particularly around infrastructure, the use of infrastructure dollars going to advance active transportation and being able to put it on the ground where it's really going to make the most difference, and that's going to be, by and large, also a health-related argument. I think it's interesting as we go through working with some of the schools around active transportation, there's been a lot of synergies with like planning and growth management and public works and Ottawa Police as an example. Even just doing school walkabouts with teachers and parents and students to sensitize everyone to the issues that the kids are facing and come up with some of the simple solutions. So the traffic calming program that the city has really been, I think, very useful just to kind of get it on people's radar that little investments and bigger investments are really going to change behavior. So I just wanted to confirm that's what I was hearing from you, and seeking those opportunities to link requests for infrastructure with the health argument.
Yes, exactly. I think that, much of it will come from our planning, growth management, and also from transportation. But as Councillor Chinishenko mentioned, when the health argument came out around Main Street, it certainly gave it that added recognition of what the broader implications are of building our environment so that we have a healthier environment, so that we have people making better choices and people being safer as well. So just to for public health, for us just to be ready to add our support to any of the applications for infrastructure funding.
Through you, Mr. Chair, one of the things that has been discussed is how Ottawa Public Health can more systematically add the health lens to city policies. So a lot of the traction that we've got to date is really around building relationships with the other city departments. But is there a mechanism that we could make that more institutionalized for whatever policy recommendations are coming from the city? I'll take that as direction, but it was a question. So it's an opportunity for sure. Thank you.
Thank you very much. Member.
Thank you, Chair, and I agree with everything that's been said about in terms of there's multiple pieces to the puzzle to make this work, and a few folks have mentioned Councillor Chernyshenko's efforts with Main Streets as well, Complete Streets, sorry, on Main Street in the last term of council, which I think showed that there's a clear shift in the planning and growth department in terms of the importance of those projects. But I want to go back a bit to the obesity rates, and we're seeing the increase in North America, and I'm assuming those stats apply here locally as well. And Dr. Levy mentioned about creating the environments or creating the conditions to help deal with that. But at the end of the day, we're changing human behavior, and that's not an easy thing. And I'm just wondering, if the strategies that have been implemented are successful, because we have been, recently starting various strategies to try to tackle childhood obesity, but we're still seeing the rates go up. So I'm just wondering what the disconnect is. Is it only, the tax thing that works that really deters people? Is there, other than fostering the environment, I'm just wondering why the success rates haven't been, in North America in general, what the research is on that.
Well, I'll start, and then Sherry, through you, Mr. Chair. Thank you very much. It's a very profound question, and the answer is not easy. I think there are probably two things that we really have to keep in mind about the kinds of interventions that we need for the kinds of problems that we're seeing in Western society. The first is the time lag. These cancers, diseases of overconsumption and underactivity, as I sometimes refer to them, are multi-generational problems, and they take decades to develop in individuals. So not only is it hard to change culture and hard to change behaviors of large groups of people that are ingrained in our cultures and in our habits, but even if we do, the change is slow to come, and the impact is slow to really be measurable. We really saw a very wonderful example of that challenge with tobacco control. It took the better part of 30 years from the time of the first Surgeon General in the United States report on the health harms of tobacco before we even saw physicians in large measure stopping to use tobacco, before we saw pharmacists stop selling tobacco, and it took another 10 to 20 years before we saw the health consequences. So we're at 50 years on that journey, and a lot of tobacco control advocates and researchers will be the first to say that job is far, far from done. So that's just an example in terms of how big the challenge is, how broadly based the challenge is, and how long it takes to address. But the other way I'd come at that question is that probably there's a lot of debate in the academic literature, but probably the biggest impacts in tobacco and the biggest impacts around how people behave in general come not from the individual choice pieces, but from the policies that are built around us, sometimes in legislation. And of course, we live in a free society, and people don't like governments legislating what they can do and what they can eat and so on. So we in the public health community are often wear the nanny state mantra or mantle. And I, will sometimes say 200 years ago, people like me and people on boards of health like you were talking about clean water, and no one complains about the fact that government regulates clean water today. So that might be nanny statism, and it might just be common sense, but we accept it. I think that the biggest challenge we have is that the biggest impact pieces are the pieces that are going to take local, provincial and federal government legislation and regulation, and they're not popular.
Can you elaborate on those specifically, some of the ones that are effective in your mind that are also not popular?
Well, the one I'd probably choose as an example is what we saw in New York City with some the Bloomberg initiatives around bringing some form of restriction onto the kinds of sugar sweetened beverages that could be sold in municipal environments, and the kinds of restrictions that were proposed were preventing the sale of products in larger than 24-ounce containers. I think 24 ounces is it a liter? I think that's 2 liters, I think. Anyway, a big amount. Much more than anyone would reasonably consume according to health guidelines by way of fluid or what's in that fluid. And there was a profound backlash, and ultimately that was not a successful intervention. Areas in California have tried those kinds of interventions at the municipal level and at the state level. Sometimes they're successful, sometimes they're not. But it really is ultimately a mosaic of that kind of regulation, I think, that's going to make far bigger impact than additional educational initiatives. I think people generally get that moving more and consuming more healthy nutrition and less calories is ultimately going to be make a difference for them and for the society. But those candies are still at the checkout counter. So it's those kinds of things. The other one is the incentive issue. Member Lakin talked about taxation policies, fiscal policies, so taxes on junk foods. These sorts of initiatives have not had a lot of traction on the healthy eating and active living file, and these were the initiatives that made a difference on the tobacco file.
Thank you, and I guess there is, obviously, we know there's much more awareness than there was, 10, 15, 20 years ago, but we still see the disconnect in the obesity rates, and I think, whatever we end up investing our resources in, that, want to make sure that it is the most successful strategy, and, I don't think the candy's ever going to go away from the local convenience store, and I think all those temptations are always going to be present, and but your point's taken that it is a policy perhaps. For me, I also see it as a change in human behavior too, but I think, it's all of those together, and it is a difficult one, but I think if, looking at the research and looking at what's been done in other places, that we're investing in something that's going to work for the long run, obviously.
Through Mr. Chair, I might comment on a couple things. So around, social norms and behaviors. So we certainly know the trajectory has gone the wrong way in the last 50 years on obesity. I would have to say the last 2 or 3 cycles I can look at our epidemiologists is the rates in Ottawa. So we used to be at 52% of the population, of the adult population, was reporting overweight or obese, and now it's 47. Is that statistically significant? No. But at least it's flattening. And I think that when you start talking about the social behaviors, there are some trends that we know have gone the wrong way. So the very heavy marketing of highly processed foods, and how can we sensitize people to that? So menu labeling and food labels are helping with that. We had a trend where we stopped breastfeeding our kids, and that is one of the things that families can do in terms of people being able to eat to their own bodies' feeding cues. So we almost have to do reverse engineering of some of the behaviors that we've learned so that more people are breastfeeding their children. So I think there are some cultural norms that have taken us in the wrong direction. How we use food is so central to what we do. It's part of our celebrations. But there was a little bit of controversy when our child care guidelines suggested you didn't need a birthday cake every single time a kid had a birthday at the child care center. And that was difficult for some people to adjust to. There are other ways to celebrate, but but we've normalized some of these things. So I think it takes time to change them. One of the things we look at as proxy is, are people trying to eat healthier? Are they increasing their consumption of fruits and vegetables? Are they making more informed choices? Are we going to be able to see some changes in physical activity behaviors, or at least reducing sedentary behaviors? So are we minimizing the amount of time that kids are spending on screens? Are we encouraging our kids to get out and play and climb a tree and stand on a log versus being really keeping them indoors, thinking that that's safer? So I think we've had some negative trends that have worked against the obesity, but I'm very optimistic that these kinds of conversations bring this into the fore, and then we can make some collective decisions around how we might be able to influence environments going forward. But change does take time.
Thank you very much. And Member Kapoor, you had another comment?
Yeah, I just want to build a bit upon the lessons that we've learned from tobacco control, which was that a lot of the change wasn't individual choice, but the environment that supported them, and denormalizing those behaviors, actions that contributed to use of tobacco. Dr. Levy mentioned the removal of the power walls, which were considered ubiquitous and were considered they were there, just there. And it was a matter of thinking that they had to be removed. And the comment that we're not going to get rid of the candy bars at the exits and at the caches, the other important lesson to remember from tobacco control was that we were and still are consistently pushing against a marketing headwind. And I think that's the lesson that we need to definitely incorporate in healthy living and healthy eating, is that we have this strong headwind of marketing pressures that are aimed solely at normalizing overconsumption and consumption of energy-rich and nutrient-poor foods. So for me, that's as big of an issue as some of these individual choices, that if not bigger.
Thank you very much. And I just wanted to add one more thing to what you mentioned, Ms. Negro, is the fact that working cooperatively with all our partners, especially at city level, where you try to work with all the departments in terms of not only planning and growth management, but other departments to bring the issue of healthy eating and healthy living into focus, a lot more focus than it has ever garnered before. So, give you a small example about the walking bus program. Something very similar, simple, something that's very small, but it does have some beneficial effects to the program going forward. And it is one of those programs that, somebody mentioned about the traffic calming measures. That is one of those traffic calming measures that could be very easily utilized within all our elementary schools. And I think that's the kind of focus we need to push forward, something that's an easy win that we can get right away and move forward. Coming back to committee, in terms of the recommendation, there's 3 recommendations on this report, and I'll read them out. Recommendation number 1, approve the strategic initiative for Ottawa Public Health Strategic Direction, inspire and support healthy eating and active living as outlined in this report. And there are 5 different components to that. I won't read them, but they're there in the report. Unless you do want me to read them, I can. Item number 2, direct staff to seek new opportunities to advance health perspectives in municipal policies and programming. And number 3, approve that the chair of the Board of Health write a letter to the Federal Minister of Health with a copy to the Provincial Minister of Health and Long-Term Care and other boards of health supporting the priorities outlined in the Federal Minister of Health mandate letter to promote public health. So those are the 3 or 4 recommendations on this report. If you have no questions or concerns, can we carry those items? And the one thing that I would like to add is on the letter that's coming out of the board's chair's office, I would like to invite all of the board members to sign that letter also, just to say to the ministers that it's not just one person on the board or the chair on the board, but everybody on the board is willing to sign, put their name on it in order to move that item forward. So if that's agreeable, once that letter is written, I'll come back to the board and get your signatures on it. So all of this, is that carried? Carried. Thank you. Thank you very much, Ms. Negro and Ms. Chow, for your presentation. Now, the time is at, 6:30. Time is not running short. I mean, we have time, but I will have to move a motion at 7 o'clock to carry the meeting forward longer. The next item, towards better outcomes for communities and patients, protecting and leveraging public health in Ontario's proposed health system transformation. Do you have members of staff here to present on this item, starting with Ms. Conley, as well as Dr. Brent Mulahogny, and I hope I pronounced your name correctly, sir, to give us a presentation on this item. Just to give you a little bit of background on this, I guess it was about 2 weeks ago that the doctor and myself met with a couple of the ministers, local ministers, in terms of Minister Naqvi as well as Mr. Fraser on this item, because there were some concerns that we have as a board member and as the board medical officer of health. But we'll come back to that after, once we have the presentation and your comments and questions. So over to you, Ms. Conley.
Thank you very much. It's going to be interesting sitting at this side of the table. So as the chair mentioned, I will be presenting the public health implications of the Ministry of Health and Long-Term Care discussion paper entitled Patients First. I'm here in my role as the program manager for OPH's Strategic Support Branch. It's because my team, most notably Inga, who's joining me here today, did the policy analysis of the report, which I'll be presenting today. And as the chair mentioned, I'm also joined by Dr. Brent Mulahogny. Dr. Mulahogny is a specialist in public health and prevention medicine and consulting expert in public health systems. Following my presentation, Dr. Mulahogny will present his analysis of the proposed healthcare transformation. Just to start off with, so over the past few years, the Ontario provincial government has laid out a healthcare transformation agenda. Their agenda aims to shift healthcare delivery in Ontario with an aim to improve patients' healthcare experience and their health outcomes. Moving forward on the government's agenda, this past December, as the chair mentioned, the Minister of Health and Long-Term Care released Patients First. It's a discussion paper that outlines 4 proposals. These proposals focus on integration of services at the local level, improved access to primary care, better links between primary care and other services, and standardized and strengthened home and health care. The 4th proposal, which has the largest implications for public health, seeks to achieve stronger links between population and public health and other services. In general, the Minister is recommending more collaboration between Ontario's 36 public health units, the rest of the healthcare system, and the local health integrated networks, which are commonly known as the LHINs. The LHINs, of which there are 14 in Ontario, would be responsible for home and community care, primary care planning, as well as population and public health. To support these collaboration, the ministry is recommending transferring the provincial funding for public health from the ministry to the LHINs. The LHINs would also assume responsibility for your accountability agreement. Local boards of health would continue to set budgets. The board would continue to be managed at the municipal level. And to help with the relationship, the minister would create a formal relationship between the MOH and each LHIN. These proposals would shift the relationship between the ministry and public health, as the ministry currently allocates and reviews our budget and oversees your accountability agreement. In addition to these proposed changes, the ministry is also reviewing the Ontario Public Health Standards and the organizational standards. In general, OPH staff welcome the enhanced integration of population and public health planning into local health system decision-making. There are some opportunities and some potential risks. OPH staff identified 5 principles that should be considered and addressed to ensure that changes lead to improvements in population health and patient outcomes. These principles are: public health units should maintain their primary focus on prevention and social determinants of health, as I think was really illustrated in this past discussion that Sherry presented. Public health's role in upstream prevention should be supported. Boards of health should remain independent, and mechanisms should be in place to protect both provincial and municipal public health funding and to protect against possible weakening or diverting capacity within local public health units. As well, mechanisms should be in place to ensure public health resources are protected from potential diversion to the rest of the healthcare system. In short, staff want to ensure that they will be able to continue to provide vital public health services to Ottawa residents. As Dr. Malakny will outline, these principles and others should be considered and ideally mitigated as the government moves towards implementing their proposals. So in concluding, staff are recommending that the board write a letter to the minister to outline these key considerations and to recommend that the boards of health have an ex officio representation on LHIN boards. Staff are also recommending that the chair and the MOH consult with the City of Ottawa's AMO representative and that staff continue to contribute to the ministry's consultations. This concludes my presentation. Dr. Malakny will provide his presentation, then we will take questions. Just as a brief introduction to Dr. Malakny, over the past 17 years, he has prepared national reports on the desired design features of public health systems, a report of the public health system of Canadian provinces, and completed a survey of the structure of all provincial public health systems. Most recently, Dr. Malakny penned a white paper for Toronto Public Health, which identified potential opportunities and threats to transforming Ontario's current healthcare system. This report informed OPH's analysis of the ministry's proposals.
Great, thank you very much. And Mr. Chair, board members, Dr. Levy and OPH staff, thank you very much for the opportunity to come and speak with you this evening. It's nice to be back. I trained here, and I think the last time I presented to the board was about 23 years ago on an injury prevention issue, so it's nice to be back. And as was introduced, I think my task for you this evening is to share some of the experiences and observations that have occurred across Canada with regionalized health systems and integrating public health into that we can learn from that in terms of how to view the proposals from the Ontario government that are included in Patients First. In terms of what I bring to this, I've worked as a Deputy Medical Officer of Health in a regional health authority. And in the last 17 years, a major part of my interest has been the design and functioning of public health systems, and I've done independent reviews of several provinces and consulted with others. So I'm happy to share what we've seen. Now, in order to be able to do this, there's some caveats and considerations. First off, Patients First is a very high-level discussion paper. There's not a lot of detail, which makes it difficult to respond to specifics. The other thing that I would warn is that much of the terminology that's included in this paper, as well as in these kinds of regionalization processes, things like population health, equity, prevention, promotion, can mean very different things to different sectors. So, most of the people in this room are from the world of public health, and immediately when I say those terms, there will be a certain meaning that comes to mind. In healthcare settings and my dealings with healthcare executives, they use those same terms, but they typically use them in a very different way. So again, that makes it difficult to fully understand what the provinces has in mind in their paper. The context here in Ontario is a little bit different. Our LHINs are different from RHAs, or regional health authorities elsewhere, because when the regionalization processes occurred in the 90s, one of the first things that governments did was strip the boards and strip the executives. So that, of course, that has not happened yet here in Ontario, so it's a little bit different context, but the stated rationale is still very similar in terms of what is being stated by government here and elsewhere in terms of improved linkages, integration, emphasis on prevention, promotion, etc. The other thing, and I'll come back to it at the very end of my remarks, is that Ontario has a unique package of design features for public health here that are not present in other provinces and deserve attention and protection and strengthening. And those are the standards, dedicated transparent funding, dedicated governance, as well as accountability agreements. So when I look elsewhere across the country, I would describe it as a mix of potential opportunities and demonstrated risks. And I'll talk about each of these, but just to give a high-level overview. So the opportunities are twofold: bringing a population health perspective to healthcare planning, as well as better integration of healthcare services. The risks, though, include a reduction in public health capacity, as well as barriers to engagement with community and municipal partners for action on the social determinants of health. So really the net impact is how the opportunities and the risks balance out. So let's drill down a little bit on each one of these. So with respect to strengthening healthcare planning, I would characterize this as a potential opportunity because its realization elsewhere in the country has been very uneven. And in most places, really has been left to chance, not design. And where it has occurred best, and probably the best example I could come up with would be Saskatoon, which has been building their capacity in this area for the past 15 plus years, is that there's been a combination of strong and interested leadership on the part of the RHA to have this happen. At the same time, there's been strong leadership from public health as well as capacity, particularly epidemiologic capacity, because being able to influence healthcare planning is not simply about going to some meetings. You need to be able to crunch data and bring those results to the table and explain what's going on and have that influence decision making. So there's some definite capacity issues involved here, as well as actual interest to make it happen. The other opportunity is about integrating services, and the best examples that I've encountered and hear people describe are those areas where public health is involved in direct clinical services, things like postpartum follow-up, breastfeeding support, immunizations, communicable disease control, those sorts of things. And as we just heard from the preceding presentation, much of what public health does and the unique aspects of public health do not involve the clinical delivery of services to individuals. However, in an RHA environment where the dominant culture and decision-making is around clinical care services, the real tendency is for public health's focus to become reoriented from keeping people healthy to the planning and delivery of clinical services. So those are the potential opportunities. So let's talk about risks. So risk number one is a net reduction in public health capacity to fulfill its function and mandates of keeping people healthy. And this happens in a variety of ways. I'll just touch on a couple. So the first is just loss of funding and positions in public health that just no longer exist. For example, I did some consultations in multiple provinces last year as I was developing competencies for health promotion practice. And I had difficulty identifying health promoters and people doing oral health promotion in some provinces. And I asked, well, why am I having trouble finding these people? And the answer was, well, over a period of years, with the pressures of the acute care side of the house, those positions had no longer been funded and continued. So the first off is just direct loss of funding. The more nuanced and subtle effect is the capacity that exists in public health is diverted and reoriented to planning and delivering illness-related care. So the public health staff, instead of working with community partners, are focused inward into healthcare delivery. There's other mechanisms, but they're not as prominent and as relevant for Ontario. Now, this issue of loss of funding, and this is a question that I was asked by the TPH board, Toronto Public Health Board, so I thought I'd add a slide for you today. In terms of this concept of public health funding being protected in regionalized processes. And I couldn't come up with an example where this has worked well. My experience in going into provinces and asking them to provide their budgets for public health, in many places they are unable to. They cannot track public health funding. It's part of global RHA funding, and the RHA makes the decisions. There were a few places, provinces where at the time of regionalization it was identified that there would be a one-way funding valve. Only new monies could flow to public health, didn't happen very often, and monies could not be redirected out of public health. But people found ways to circumvent that. One way was, for example, ensure public health has a surplus, and then at the end of the year redirect it to fulfill the shortfalls on the acute care side. The other thing I found is that the budgets that provincial governments tell me that are being provided for public health, prevention, promotion, when I go into the RHA, they are much larger than what's actually for public health. And often the reason is that they've augmented the public health budget with clinical prevention services. So one example is the hospital providing dietary counseling to patients with diabetes. Is that important? Absolutely. But that's treatment. It's preventing complications in diabetes patients, helping them have better control. Important, absolutely, but that is not a public health function. So that was the first risk, loss of funding and capacity. The risk two is the barriers to engagement with community and municipal partners for action on social determinants. And as we just heard about the healthy eating and active living, that's the key strategy, is to work with other partners to make change happen where people live, work, and play. And this happens through a few ways. So the first is that if staff spend most of their time focused on planning of health services, they don't have time to work with community partners. The second thing that happens is, in some cases, RHAs will actively discourage partnering. I was speaking with an MOH colleague a couple of years ago from a large urban center who had been working with partners for 2 years on a homelessness plan, and his employer said, "You will stop that. We're in the healthcare business, you will focus on delivery of healthcare services and stop partnering with these outside people." An additional issue, which is also an issue in some parts of the province, I don't believe here, is a misalignment of health authority boundaries with municipal and education partners. So if your boundaries don't line up, it's difficult to have those conversations and joint planning together. I focused on Canada, but we're not unique. England's been in the regional health system business with integrated public health for a longer period of time than us. And despite their best intentions for this to work, the government announced in 2010, acknowledged that it had not worked, that public health budgets had been squeezed, staff disempowered, and the system fragmented, and the current plan is to realign public health with municipalities. Unfortunately, I would have to report that's not going well. In that 2010 report, they said that public health budget would be, I think ring-fenced was their English term, and protected, and that has not been the case. And as they are realigning with municipalities, the budget is being going different places, shall we say. So what are the implications for Ontario? Well, at a high level, so first off, I'd say need to have a conversation about what are the goals. What's actually the problem that's trying to be solved here, because it's not explicit in Patients First. And beware the terminology. As I said, I've had conversations with healthcare executives, people in primary care reform, and we think we're talking the same language, but then once we drill down and talk details, we realize that we are not. Those opportunities, if they're pursued, do it by design, not by happenstance. If wish a population health perspective in planning, then set it up to succeed. And I would say, as a Board of Health, beware diversion of resources, because where are all those EPIs going to come from? Where is the medical officer of health's time or other senior leaders who in other places can spend upwards of half their time in this particular area? With respect to integration, if it's to deal with overlap or gaps or problems with inequity of access, then sure, I mean, have that conversation. Now, of course, those conversations happen now, but beware that the rest of what public health does, which is important, does not get wrapped up in this and diverted. And mitigate the risks by design. Ensure that the strengths of public health here in Ontario are retained and maintained. So those are my overall comments I want to provide with you this evening. I'm happy to take any questions or comments.
Thank you very much for your presentation and your comments, Doctor. Any questions? Dr. Kapoor?
Thanks for the presentation and for the information. One of the things that I was noticing when I was reading the government proposal and the report also came up here, where we talk about, or they talk about SDOH, the social determinants of health, and the application on a municipal level only. And I see all of the other discussion in the report on the LIN and using that as the level of integration, of the unit of integration, that it only is only looking at the health system, and it has no whole of government approach for social determinants of health. And I'm not sure if you've seen that elsewhere, because the LHIN's going to be at a mid-level, a meso. You could apply it at the municipal level, which I'd argue our boards of health do a fair job of. It should also be applied at a provincial level, which I'd argue is much less well done. But integrating it at the LHIN level, I see as a huge absence. It's not going to be effective in either way. I'm not sure if that correlates with what you've seen elsewhere or not.
Yeah, no, it's a good question, and it prompts a few things. It's vague. Patients First is vague. I mean, the name itself sends up signals because we're talking about patients and not health. Right, but fine, it's branding, so we'll put that aside for the moment. This issue of social determinants of health, and from right there I want to go to inequities, because the reason we have inequities in health is because of differences in social determinants of health. And depending on the levers that we're trying to influence, just like the earlier discussions around marketing to kids or labeling, depends on which levels of government it makes sense. And the more that those are aligned, the better. So yes, there's some things that you can do that only can do at a municipal level, and that's one of the advantages for having the close integration of public health with municipal government here in Ontario, which, as I said, England's going back to. Now, are there levers that need to occur at the provincial level? Of course, because some laws can only be, whether you're talking about income, education policy, social assistance, many of those policies are set provincially. Back in the day when we had a Ministry of Health Promotion here in Ontario, the vision when that was announced, and it was ironic because I was working in Nova Scotia at the time trying to get the two ministries to work together, and the government at the time here in Ontario said, we want to have a Ministry of Health Promotion because it's working so well in Nova Scotia. And I wanted to raise my hand and say, well, can we talk about that? But anyways, I digress. The vision here in Ontario, when the Ministry of Health Promotion was established, was to have this whole-of-government approach where senior representatives, the deputies, and the ministers would work together across the ministries to provide a whole-of-government perspective to health. And it really didn't take off. Probably the best example I can come up with in Canada, where they did a whole-of-government approach, where they actually instilled in the Public Health Act the Section 54 requiring public health to review and comment on any other legislation of any other provincial ministries that could influence health. So it basically set up provincial public health in Quebec to basically look at any other pieces of legislation that could have a health impact. So it's sort of like the provincial example of what happened here municipally when you were having that issue on Main Street, where public health said, here, we have a voice, and there's a health perspective to this. So that's probably the best, and it's certainly legislated example where I can think of a whole-of-government approach in this country. The thing that concerns me in particular about the equity issue and Patients First is what kind of equity are we talking about? Because my sense, and the way it's used in that document, it's mainly equity of healthcare services versus equity in health. Because to have equity in health, then we got to go upstream a bit to say, well, how do people maintain health and well-being and avoid illness and recover from illness that's independent of healthcare? Healthcare important? Absolutely. Equity of healthcare services? Absolutely important. But equity is more than just equity of services, and it's equity in opportunities for health. And I don't see that in Patients First. And I think there's an opportunity for public health organizations to reinforce that with the provincial government.
Thank you. You, as I said, preempted my second question, which was about inequity in health, not services, but in health. So my comment, Chair, would be that if we approve this report and the recommendations, that in the letter that goes out above this report, for the cover letter with this report, is that we would, rather than trying to change the report, that in the letter we mention the concerns and the risks towards the application, towards the correction of inequity in health, as well as the application of the whole of government approach at the provincial and other levels other than municipal as it pertains to social determinants of health.
Thank you very much for that, Member Kapoor, and we will include that kind of language in the letter as one of the recommendations going forward. Member Fleury?
Yes, thank you, Mr. Chair. You gentlemen had a very theoretical conversation. I want to bring it back to perhaps what I believe is practical. Other regions of the province are surrounded by generally medium-sized municipalities. We happen to be one of which does not have major municipalities nearby, especially when you start looking at the landmass, right? In superficie, we're the size of Montreal, Toronto, Edmonton, Vancouver, Calgary, and Montreal added all together. And I think that adds a specific lens into the regional proportion that needs to be factored in. I was asked by a French media last week, give me an example of why wouldn't the LIN be a great region to conceptualize the issue? And, you know, anything could be put in place with a significant amount of money, but I use the example of water. We in Ottawa, most of our residents have access to water that is city protected, that public health is involved in and legislate and monitors. We have complexities because we do have a big rural portion of our city. But if you keep adding the rural proportion to it and you add other water systems, anything can be done. I don't want to say it couldn't, but you do get into a different aspect. And I think that relates to sexual health. That relates to the strategy that public health had around don't be that guy into bars. Because of the big city we are, because in terms of land space, but also in terms of proximity, we also have that element. The other one to consider is our proximity and the cost of healthcare, specifically relating to the Quebec border. How many people from Quebec cross and ask for services in the health field in Ottawa just because it's not adequate on the other side of the river? I think those are all, in the review of the patient-first elements, these are actually baselines that can't just be generalized across the province. There's factors locally that influence that. And I'm concerned that if we do go into, don't get me wrong, I think change is good. I think that changes in terms of technology, in terms of integration, in terms of renewal and efficiencies are great. I'm concerned though that if we fit into the LIN process, we actually lose the local ability to be flexible, humbled, and responsive, which in my mind fits to the first criteria that was brought up relating to Syrian refugees. So take the big region, take the LIN as an example, and look at the refugee-specific issue. We are the big city. We're the ones who are dealing locally with the vaccination, with the monitoring, with the dental issues that were highlighted by the doctor. When you look at the LIN region, you'd say, oh, well, you know what, it's a small number. You wouldn't, as a province, you wouldn't look at the number. When you look at our specific agency, you say, wait a minute, we're seeing that pro rata, that Ottawa has actually a portion. So, and then my last argument on why I don't think it's a good approach is that if there are healthcare specific issues, deal with them in the healthcare specific context. If, you know, we recently heard about the board of the Ottawa Hospital. I know it's a contentious issue, but if it's done elsewhere in the province where hospitals are dealt with at the RHA level, fine, do those corrections locally. You'll hear very little from us. But if that's not the case, if that's the element you're trying to fix, don't pull us in, because if you pull us in, we're not in the game of competing with big hospitals. We're not saying that urgent care shouldn't be a top priority. We're saying that what we do is valuable to not get people into that emergency care into the hospital itself. So, I'm not trying to make a big spiel. I just wanted to give local arguments on why I think there's key structural, fundamental issues in the patient first review.
Thank you very much, Member Fleury. Just before you respond, sir, I want to go back to Member Kakish to move a motion to go beyond 7 p.m.
Be it resolved that the Board of Health approve the meeting time be extended past 7 pursuant to subsection 8(1)(c) of procedural bylaw.
Is that carried? Thank you. Okay, Doctor, the floor is yours.
Great, thank you. And I just have a few thoughts in terms of supplementing your comments, sir. In terms of getting public health to function right, there is an issue of critical mass. You need a sufficient population to support the sort of capacity that you govern. In some other parts of the province, there is an opportunity. In fact, there have been recommendations waiting to be enacted since SARS to deal with some of the very small health units that have limited capacity. And so perhaps through this process that those can be remedied. But here in this part of the province, I agree with you. It's unclear to me what the advantage will be, because I think the circumstances for City of Ottawa versus other health unit areas, which is unclear how they will be addressed in Patients First. It's possible, though, that's what they're referring to as sub-LHINs, so that the sub-LHINs will align with this idea of existing public health units, but then it's totally unclear how these multiple sub-LHINs would then relate to each other and relate to the overall board of the LHIN. It's unclear. There's no details in Patients First. But certainly, as we learned with SARS, and it was written about at that time, a lot of what public health does is local and it's on the ground, and it's the local relationships and it's the local levers, most of which are municipal. Are there important interactions that one needs with the healthcare system? Absolutely, and they happen on a daily basis with the different programs that public health has. The issue is I think the sorts of reforms that the government is suggesting to make, and whether they will be enacted in a way that maintains and strengthens public health or does otherwise.
Thank you for that. Member Taylor.
Thanks very much, Mr. Chair, and just by way of comment and then a question coming out of that, and I think you and I had spoken, as well as Dr. Levy, that this topic and the Patients First proposal came up at the last AMO meeting 2 weeks ago in Toronto, and we spent about an hour and a bit on it with most of the other mayors or representatives of AMO participating, and this is causing the same level of concern across Ontario. And there's obviously, to Councillor Fleury's point, depending upon the size of your municipality and its geography, there are other concerns. Some of the ones that stood out for members there were the absence of things like a discussion about mental health, the absence of kind of those cross-boundary things between preventative health and clinical care, like community paramedicine, which is becoming more and more prevalent. But AMO's request was that they, in addition to providing feedback as we're doing, they are requesting to form a group that would interact directly with the province, and so we're waiting to hear back from the province on whether they accept that or not. I'm interested to hear, you had indicated, Doctor, that you had briefed Toronto Public Health, I believe, and interested to hear on if you've had any other interactions with other health units around Ontario and how they're dealing with this.
One thing that we can say is just that we went through and searched the other health units. So out of the 36 health units, 12 have actually sent information to their board, and their information ranges from receive this report for information to more action oriented. I can say that Durham, Sudbury, Toronto and Niagara all had similar reports to ourselves. I think these are the ones that Israel connects with, the closest ones. They have the capacity to be reviewing these reports. I think the implications, as Councillor Fleury has mentioned, within each of those would be very different. Toronto's report had highlighted some of the same issues that we did, and same thing with Sudbury. So I think the conversation within some of the health units are very similar, and some of them are not as much. So I think it kind of goes with Councillor Fleury. It's difficult to kind of make that generalization across the province.
The thing that I would add is the background paper, about a 12-pager that I wrote for Toronto Public Health, was made available to all of the other health units in the province, so all that information is available to them. And I'm aware that the Association of Local Public Health Agencies, ALPHA, which of course has MOH as well as board representation, is preparing a response. And they've struck a small working group to prepare a response to the province, and I'm one of the consultants that's advising them.
Thank you very much, Member Taylor, and thank you for representing our concerns at the AMO at the last meetings. So thank you for that. Any other comments or question on this item? Member Kakish?
Thanks, Chair. Just a quick question. In terms of the legislative process, the province is moving forward with this, so I'm just wondering if there's any united position from municipalities. As this Councillor Taylor mentioned that this came up in AMO discussions, but from a legislative perspective, given that the vast majority of our funding comes from the province, is there anything really that we can do other than make the best of the situation that's in front of us?
I'll give my consultant perspective, and I think staff would probably want to advise the board on this. It's interesting. My sense of things has evolved a bit over time. I mean, initially, my initial response was, this has happened. It's the province has thought this through, made a decision, and the question is, how do we, try and make the best of it? But the more I read it and have conversations, my sense is they may not have thought this through as fully as perhaps some of the other components of Patients First, which had, I think, been clear items of objectives for the Ministry of Health with respect to primary care, and certainly home care and the CCACs have become a prominent issue. So I think there's a lot of detail that has to be filled in here. So I think there's an opportunity to express your concerns and willingness for dialogue. But certainly I have no direct knowledge in terms of what legislation the province may be drafting and what their timetable is.
Just staff, can staff comment on the timeline in terms of that?
Speculatively, through you, Mr. Chair, I think Dr. Malachny's characterized what is sort of out in the ether there very, very well. There is soft signals, or there are soft signals that legislation will be tabled in the late winter, early spring. That legislation will resemble the kinds of proposals that are put forward in Patients First. Clearly, the policy traction that's been at the ministry level over the last several years has focused on the other components of the paper rather than on public health, notably home care and perhaps primary care. The degree to which public health is sort of a cleanup piece, once they're doing this, they'll just sort of do some of the stuff that has been talked about in the past. There are differing opinions as to how that plays out, but certainly it's clear that the overarching objectives of the provincial strategy are very heavily focused on improving patient outcomes, and that there is a perception at different levels of the ministry, both political and administrative, that public health expertise can be brought to bear in order to help the ministry achieve those objectives. That is complimentary and flattering, But of course, the concerns that have been expressed in the report and that we've heard about from other jurisdictions are also very real. My own gut feeling is, and that's as much as I've got to offer, is that Dr. Malachny has characterized it exactly correctly, that some of the issues weren't as well thought through or as didn't benefit from having been part of the policy workup for as long when they pertain to public health. But I do believe that that there is a definite intent to bring certainly the staff of public health in a planning role much closer to the LHINs and to ensure that boards of health are held accountable for deploying the expertise that is manifested in the Office of the Medical Officer of Health to LHINs. I think that's a two-edged sword. I think that's probably real. We'll probably see that in the draft legislation as a minimum. And the other pieces around funding flows and who has the relationships and where the accountability agreements sit are probably the kinds of things that might be delayed for another day and for more reflection. So if that's in fact a correct assessment, that leads to the report that I've put before you today with the help of the staff, Gillian's team and Enga and others. But the real risk there is that, even if we don't see the diversion and erosion of public health resources and money into the future, the real risk there is a diversion of our expertise and attention into other important areas that are certainly areas that we'd be interested in working, but it would have to be at the expense of areas that we're already working. And the other piece, which is why recommendation 3 is before you, is that if that is the intent of the ministry, my opinion is that you shouldn't be asked to provide the expertise in planning in order to inform LHIN decision makers. You should be asked to bring to bear the expertise that exists within this Board of Health at the decision-making level rather than at the influencing of the decision-making. And that is why I think there's a very real opportunity, which has not been widely discussed, to actually seek governance responsibility if the ministry is intent on bringing us closer together.
In the presentation, you mentioned some of the other jurisdictions that you've looked at. What generally is the financial savings for something like this, an overhaul like this?
Just clarification, savings from doing this regionalization process?
Right, from the restructuring in other areas.
That's a very good question. I don't think there is a clear answer. It's even difficult to know what the budgets are for public health at a point in time, let alone trends. But certainly it appears that the amount being provided to public health has decreased, which has been the fairly universal experience. There are so few places where there is substantial public health input into healthcare planning, and I don't think there's a number on it. I think they would say that it's valued where that happens, but those are the outliers. In many places, public health doesn't have that capacity. Public health is often fragmented, which I didn't get into. And in many places, public health is buried in the organization and has very little access to the executive team or the board of the health authority, let alone influencing healthcare planning.
Thanks. I was just curious because I assume one of the main reasons they're doing this is obviously because of the financial burdens that all governments are facing now, and I was just wondering how the magnitude of that.
Hypothetically, I think if one looks with the rosy picture at Patients First that, as Dr. Levy said, it's flattering that bringing public health's perspective and expertise to bear in terms of thinking about healthcare. And by the way, there would have to be work to bring public health people up to speed to be able to do that, because that's not part of what they do, but could be trained to do so. That theoretically that healthcare planning decisions, everything from location to how services are provided, identifying gaps, identifying problems with access, could be improved, but I've never seen anything published to say this is what you can expect.
Thank you. I guess my final comment, Chair, would be to, our members to reach out to our local MPPs who we have a good working relationship. We've had Minister Naqvi here in the past, and to highlight those issues or concerns locally as well with them so they can take it to the cabinet table in Toronto. Thanks, Chair.
Thank you very much, Member Kakish, and that's why at my opening of this item, I did mention that we had those meetings, and we will continue to work with our local ministers. Obviously, that's where the benefit is. But having said that, and if the board approves this report going forward, there is some direction that we're providing to the minister going in terms of looking at the whole issue or holistically, and if not, then there are some recommendations here that we're providing also. So thank you for your comments. Member Lakin.
Thank you, Chair. Just a question on your sense of the use of the expert panel that you identified in the report that would act as, from what I can gather, an advisory body to the LHIN and act as a liaison between the LHIN and public health units. Do you have any insights as to whether this expert panel is simply advisory in nature or whether it represents another opportunity for governance and oversight?
Details are scarce, and so I don't have a sense. The one thing, though, that raises a bit of a concern for me is the review of the standards. And I know that there's going to be public health representation there, and I think some concern for the extent to which the existing standards might be reduced to free up a resource transfer or reorientation towards this new responsibility for public health. I mean, having seen provincial governments in other provinces work, because there's only 4 provinces in Canada that have standards. This is the only one where they actually have some teeth to them because funding comes with it and there's accountability agreement. So it's part of your safeguard to ensuring the integrity and orientation of public health in a comprehensive manner. So if the standards are being reviewed at the same time you're looking at increasing the responsibilities for public health, I would tend to think of those may be related.
Thank you. So in view of that, Mr. Chair, I wonder if I might recommend that as part of your letter to the Minister, that in addition to making a recommendation that members of boards of health be represented on the LHIN board, that they also be represented on the expert panel.
Thank you, Member Lakin, and we will include that as part of the letter going forward. Any other comments or questions? If seeing none, thank you very much for the presentation, Dr. Malakny, and thank you, Jillian, for the presentation. I'll turn the recommendations back to committee. So I'll read the recommendations, and then we can see if we carry this item or, we postpone. The Board of Health for the City of Ottawa Health Unit, number 1, receive for information the Ministry of the Health and Long-Term Care's discussion paper entitled Patients First, a proposal to strengthen patient-centered healthcare in Ontario. Item number 2, approve that the Chair of the Board of Health submit the report to the Minister of Health and Long-Term Care and write a letter to the Minister of Health and Long-Term Care outlining the key considerations for successful health system transformations as outlined in the report. A, leverage the role of the public health. B, maintain independent governance and accountability. C, protect public health funding. D, strategically integrate population health priorities, assessment, and surveillance. And E, enhance public health capacity. Item number 3, approve that the Chair of Board of Health include in the letter referenced in recommendation 2, a recommendation that boards of health be afforded ex officio representation on local health integration network as well as boards in order to collectively influence priority setting. And this is where we'll include your recommendations, Dr. Lakin, under item number 3. Item 4, approve that the Chair of the Board of Health, subject to the approval of the recommendations 2 and 3, forward the letter referenced in recommendation 2 and 3 and this report to all Ontario Boards of Health, Ottawa City Council, the Association of Municipalities of Ontario, Association Local Public Health Agencies, the Champlain Lynn, and local members of provincial parliament as part of the ministry's consultation on their proposal, including the Patient First, a proposal to strengthen patient-centered healthcare in Ontario. And number 5, recommend that the Chair of Board of Health and the Medical Officer of Health consult with the Ottawa City Council's representative for AMO regarding municipal perspectives around the proposed changes in governance and funding. And number 6, direct staff to contribute to the minister's consultations as required. And we will include Dr. Kapoor's recommendation also in this letter. So if that's carried, and yeah, I said member Lakin. Is that item carried? Thank you very much. Item number 6, Healthy Start, Part 3, Toddlers and Preschool Health. And I'd like to welcome Marino Francipolini as well as Sherry Nigro back again for the presentation.
Thank you, Mr. Chair. Bonsoir, mesdames et messieurs. I'm Marino Francipolini, gestionnaire de la programme de santé familiale et en milieu scolaire. And I'm pleased to be here to table for information the third Healthy Starts report, one that focuses on toddlers and preschoolers. Knowing that what we know today about the importance of these early years, I want to give you an update on how we are working to make it easy for families to get support when and where they need it. So who are our families and children in Ottawa? The one characteristic common across all families is that they are all unique. Some live in rural, some urban, some suburban areas. 15% are considered low income. 13% are single-parent families. And there are some parents and children that struggle with mental illness or physical disabilities. That said, what's going on with our little ones? Many of us may have seen, or as parents ourselves, experienced our little ones melting down in our grocery store, at the park, or at school. When my kids recently started school, going from being home to a full day en maternelle, the tears and fear were so apparent, both for them and for me. Our partners in schools are seeing the outcome of the preschool toddler years coming into the classrooms. What's raising concerns is the negative trend in school readiness scores with children in the early years. We are seeing increases in aggressive, anxious, and fearful behavior, and less pro-social and helping behavior. So we are working to support parents before their kids arrive in school. Ottawa Public Health has been working to integrate our services so that there is an appropriate service to offer each family, regardless of education, income, or geography, provided at the right time by the right provider. Let's walk across the continuum of these service options. We understand that all parents benefit from support. Based on feedback and consultations, we know that most parents in Ottawa routinely look for information online. And over the past year, Ottawa Public Health has seen tremendous uptake of our Parenting in Ottawa website and the Facebook page. Some families face challenges and may need more support than others. Those that have individual questions can ask for specific answers from a nurse through our phone line at 613-PARENTS and on our social media channels, such as the Parenting in Ottawa Facebook page. Some families may benefit from longer-term supports and can have a home visit from a nurse. One area we have made great strides in is our weekly drop-in services. Once known as Baby Express, our now Parenting in Ottawa drop-ins have evolved. We used to support from birth to 1 year, and now we are available to families with kids from prenatal to 6 years of age. We used to have 15 sites, and we are now 20 sites across the city every week. We used to be mainly a standalone service, and we are now integrating with other community partners and services, like at Centertown, Vanier, Rideau Community Centre, and the Stittsville Library. This is important because working with our community partners, we are reaching families where they live, in centers where they're comfortable and already frequent, and linked with other services they also need, avoiding duplication. One particular transition point that is a major stressor for a large majority of these families is going back to work. One big concern is finding childcare that will work for the family and the stage their child is in. With so much change in the childcare sector, Ottawa Public Health is collaborating with childcare operators and administrators like Community and Social Services to support these families. One of our collaborations has been to host the childcare services staff on our Facebook page to explain some of the transformations that are happening. Another collaboration has been to work with childcare centers themselves to implement healthy eating and active living guidelines, as well as developing practice champions in these centers that can bring a focus on early child mental health. Another challenge during this transition period can be the actual stress of leaving your child and going to work. Parents often struggle with the balance of work and life, lack of time to prepare healthy meals, setting aside quality time with children and their partners, balancing work pressures and getting enough sleep. Workplaces could play a role in reducing this stress, and Ottawa Public Health is supporting employers in adopting family-friendly policies. So in closing, Ottawa Public Health will continue to listen to families and strengthen the services and supports for families in Ottawa. There is good momentum already to deepen service coordination and integration, both within Ottawa Public Health and with our community partners. We all have a shared goal. We all want a city where children can reach their optimal potential and be ready for school and for life. Working together, we are trying to make it easy for parents to access support and give their children the best opportunity to be healthy and happy. I am very pleased tonight to have some of our partners here with us, including Marissa Moher from the Ottawa Carleton Youth Initiative and Jennifer Theriault, co-chair of the Best Start Leadership Committee, who we'd like to invite up to say a few words themselves. Thank you, Mr. Chair.
Thank you very much, Mr. Francis Pillai. And I would like to welcome Mrs. Marissa Moore, Director of Ottawa Child and Youth Initiative Growing Up Great, as well as Ms. Jennifer Theriault, Early Years Coordinator, Centertown Community Health Center, Best Start Ottawa Leadership Community Chair. And we'll let them speak if the committee is okay with that, and then we'll come back to questions and comments from committee.
Hello, thank you. So I am Marissa Moore. I'm the director with the Ottawa Child and Youth Initiative Growing Up Great. We're a collaborative of over 80 organizations and agencies with a shared commitment to ensuring that all children and youth in Ottawa have the opportunity to reach their full potential. Recognizing the power of collective advocacy and collaborative community planning and efforts, the initiative provides a platform for groups to work together and guide and influence public policy, systems and practices aimed at nourishing positive, healthy growth of children and youth in our community. We're grounded in the framework to promote healthy development in children and youth, which illustrates that families, schools, neighborhoods, community, and government all have a role to play in enabling optimal development. One of our strategic priorities that I would like to speak to today is infant and early childhood mental health, and collaborating very closely with Ottawa Public Health on this. We're currently working with a steering committee which includes a wide breadth of organizations in Ottawa that are interested in addressing this concern. So over the last decade, our community has come together and made significant impact in improving the systems, services, and programs for infants, young children, and families, especially in the areas of language and communication. However, despite these strides, 25 to 30% of children are considered vulnerable and not ready to start school. Specifically, schools, childcare, and early learning programs are dealing with a decrease in early skills related to emotional maturity and a child's ability to deal with everyday stress. When we look at older children and youth, we find that 1 in 5 youth experience a mental illness. Increasing rates of anxiety and depression are placing pressure on the system's ability to respond at the assessment and treatment levels. What we do know and are becoming increasingly aware of is that early childhood experiences and secure attachment in the early years are foundational to healthy development and wellness across the lifespan. The experiences children have in the first 6 years last a lifetime. Early development, including mental health, can influence a child's developmental trajectory, their capacity to learn, their physical and mental health, and their behavior throughout their life. What happens early shapes outcomes throughout the individual's life. And recognizing the critical need to support attachment and emotional health, the Ottawa Child and Youth Initiative, along with its partners, hosted a professional development opportunity in November 2014 to provide training to over 160 professionals on infant mental health. From this training, a further community conversation with early childhood and mental health service providers, we developed an infant and early childhood mental health framework to direct our next steps and strategies. And this framework is guided by 3 tiers required to support a system that recognizes the importance of infant and early childhood mental health. These tiers being promotion, protection, prevention with early intervention, and treatment. The Ontario Ministry, MCYS, has identified infant and early childhood mental health as an issue that needs policy development to ensure the availability and accessibility of services. And similarly, at the federal level, PHAC, or the Public Health Agency of Canada, has also provided investment at the promotion and prevention level. It's an exciting time in Ottawa as there's significant momentum around infant and early childhood mental health. Agencies are aware that effective infant and early childhood mental health policies encompass the full continuum of promotion, prevention, and early intervention, and are committed to working collectively to identify strategies targeted appropriately for the unique needs of families, schools, and our communities. Essentially, there are a couple best practices which are suggested, and many of those we're working on currently in Ottawa, which has us well positioned for continuing this work. Infant and early childhood mental health outcomes should be integrated into existing programs. Ottawa is well positioned to meet this need, as there are a number of agencies that are already doing great work. Training and education for professionals, which are the practice champions, which Marino spoke about, working with young children and their families in the community on promotion and prevention will strengthen professional competencies and build overall community awareness on the importance of mental health across the age span. This will increase and lead to a system of wide practice and policy change. Supporting parents and families of young children with accessible and coordinated services to nurture mental health for all, and increase resources of early identification and intervention on infant and early childhood mental health disorders. The long-term social and economic impact of mental health problems among infant and young children is significant, and making this a priority is of critical importance for government and communities.
Hi, my name is Jennifer Terrio. I am the co-chair for the Best Start Planning Table, and I work at the Centertown Community Health Center as a early years program coordinator. So the City of Ottawa has 9 planning tables working with service providers and agencies at the community and neighborhood level to facilitate the integration of services for children and youth, to improve services and programs for children and youth who are growing up in our different neighborhoods across the city. So last September, members from the Best Start planning tables, and there are 9 in Ottawa, and the tables are comprised and composed of numerous service providers who are working with children and young families, such as community health centers, community resource centers, the parent resource centers, and Ontario early years centers, and many more. And we had the opportunity to co-host and facilitate a service planning day with the team from the Parenting in Ottawa drop-in programs. And we really had an opportunity to have some really rich dialogue that day to look at the neighborhoods across the city and bring all the service providers together, looking at what are the services in our neighborhoods, what are their gaps, what are the needs, what are families telling us when they come to our programs and services, and what are some of the barriers. So we're able to work with some of our tools that we have to identify them, bring them together, and really share our knowledge and our experience together on that day. Look at what are the current drop-ins that are currently offered by OPH, and then look at where the new sites were. And with all that information, we were able to give it back to Marino and his team for them to go back, look at the information, and come back and talk to the community partners about moving forward with the Parenting in Ottawa drop-in. The Centretown Community Health Center is a new site, so I have the privilege of working with the team to look at how we implement the Parenting in Ottawa drop-in, and it's really been an enriching, positive experience for both staff and family members. At our center, it certainly was able to enhance our early years program in that we were able to really collaborate and integrate and co-facilitate our programs with the staff from the Parenting in Ottawa drop-in, to looking at what resources that we can share, what staff we can share, and looking at what programs and services that when families are coming to our community health center, that we're able to look at how we can help them with their parenting questions, the needs, anything that they have that they're looking in their neighborhood that we are here in Centretown, or if it's across the city, and be able to then refer them to other services as well. So we're really able to collaborate and integrate our services together by offering pre and postnatal services, as well as services for children 0 to 6.
Thank you very much, ladies, for coming to do your presentation. Any comments or questions? Either for staff or for the delegations? Member Lakin?
I don't have a question, Chair, but I simply want to applaud the Family Health team and Public Health for acting on the initiative, and in particular to hear of the great work that's going on in a variety of neighborhoods, and perhaps look forward to the day when knowing that the focus on infant mental health and improved mental health in outcomes in infants will go a long ways to reduce the incidence of mental illness in older kids and adults in our community. So I applaud the efforts and thank you for your excellent work.
Thank you very much, Member Lakin, for your comments. Dr. Levy?
Thank you, and thank you through you to Member Lakin as well. I want to thank the staff for sure, but also the partners. I know it's not customary really for us or at least for me from this chair, to pay respects to partners who are with us. But not only have you stuck with us through a long meeting tonight, and I appreciate that, but this really is a marvelous example, I think, of what we've been talking about in previous meetings, the kinds of things that go unseen in terms of public health's ability to leverage, draw dots together, and influence in the community really through partners. And I've got to say that we've got 2 examples with us tonight of the many partnerships that the Family Health team enjoy and nurture, because without the partners we just couldn't get it done. One of the things we didn't want to focus on tonight in this particular report, which is for your information, is some of the burning platforms that we discussed and dealt with over the last 2 years at budget time. This is an area within public health that is constantly under budgetary pressure. It's all too easy for an administrator in my position to divert resources or to address the urgent public health things that crop up as infectious diseases very frequently, and put resources into those kinds of things where the risk is imminent and immediate if we don't address them. But I know that our staff in Marino's team, Sherry's team, and the partners are always stretching that one little bit extra to keep the services up in the community and to really address the needs of our families and children on an ever-constrained budget. So thank you for giving me the time just to make that acknowledgement in that context tonight, and thanks to both of you for being here.
Thank you very much, Dr. Levy. Anybody else? No? Thank you again for your presentation. Thank you for, like Dr. Levy said, for sticking around with us for such a long time. So thanks very much. Moving back to the recommendation to committee, and the recommendation is that on Healthy Start Part 3, Toddlers Preschool Health, that the Board of Health for the City of Ottawa Health Unit receive this report for information. Is that received? Thank you. Now, one more item to clear yet on the agenda. Item number 8 was held by Member Fleury, and he had questions related to the item that we discussed under 5. So that item is cleared up, and so what I need to do is carry this item with the indulgence of the committee. So item carried. Thank you. Motions to adopt report. Member Kakish.
Be it resolved that the confirmation of the Chair and Vice Chair report, Chair of the Board of Health verbal report, Medical Officer of Health verbal report, Making Healthy Eating and Active Living the Easy Choice report, Towards Better Outcomes for Communities and Patients, Protecting and Leveraging Public Health in Ontario's Proposed Health System Transformation report, Healthy Start Part 3 Toddler Preschool Health report, Ottawa Public Health's Activities to Support Syrian Refugees in Ottawa report, and attendance at the Association of Local Public Health Agencies 2016 Board of Health Winter Symposium be received and adopted.
Is that carried? Thank you. Motions of items that have been given notice previously. I don't have any. Motions requiring suspension of rules for procedure. There are none. Notice of motion for consideration in subsequent meeting. Anybody have a notice of motion? Seeing none. Information previously distributed. There is none. Confirmation of bylaw. Member Kakish.
Be it resolved that confirmation bylaw number 2016-1, a bylaw of the Board of Health for the City of Ottawa Health Unit to confirm the proceedings of the Ottawa Board of Health at its meeting February 8, 2016 be read and passed.
Is that carried? Thank you. Inquiries and answers, we have none at this time. Adjournment, Member Kakish? Thank you very much, Member Kakish. And is that item carried? Carried. Thanks, everybody, for a great meeting this evening. Take care.